Good evening, everyone. Here Imran Abbas again. We are live. I am live from Dubai, and today Professor Ghulam Siddique from Islamabad, Pakistan. Great honor for me to interview such a prestigious figure. So really, it is great honor for me, and I am one of the follower of Professor. And Professor is one of the pioneer of bariatric surgery in Pakistan. And I will, hopefully in this session, we will try our best to convey our message, especially for our youngsters. So regarding, we have started this interview series with the MGB, OAGB, and then we have finished this series in June 2021, and we had a sum-up session. Then we continued this interview series with safe sleeve gastrectomy. And we had a sum-up session in January 2022. And now we have started this interview series of Runway gastric bypass. We have started this series with Professor Himpan, who is a great surgeon, and we will continue. And really, it's great honor. Personally, I learned a lot. So, sir, I will not take your time. Please, sir, over to you.
Thank you very much, Imran. That's a great honor indeed. To be honest with you, I was really looking forward to it when you spoke to me a few weeks ago. And here I am in front of you. I'm a general surgeon working in a hospital in Islamabad called Shifa International Hospital. This is nearly 600-bedded teaching hospital in private sector. I'm basically a graduate of Khyber Medical College, Peshawar, and I got my postgraduate training from Ireland, Scotland, and Wales, basically. And I was lucky enough to be involved with early time when the laparoscopic surgery started. In fact, I did my first laparoscopic cholecystectomy in June 1990 when I was a registrar in Dublin. And the journey started from there. And I had a great time. I was registrar in Glasgow Royal Infirmary for 2 years in pancreatobiliary unit and coloproctology. And then I was registrar in Cardiff, again, pancreatobiliary unit. But those days, laparoscopic surgery was limited to mostly lap colis. Bariatric surgery, to be honest with you, I never thought of becoming a bariatric surgeon and didn't have much knowledge of bariatric surgery. But when people started advanced laparoscopic surgery, then bariatric surgery came to surface and people started showing the interest in bariatric surgery because the results were brilliant with minimum morbidity as compared to the era of open bariatric surgery. And many people who were going through this phase of evolution, I was one of them, enthusiastic, and started doing advanced laparoscopic surgery, and bariatric surgery obviously was part of that. My journey of bariatric surgery started from 2009 when we had Mufazzal Lakhtawala, who came all the way from Bombay, and he demonstrated sleeve gastrectomy in South City Hospital in Karachi. So Mumtaz Meher, a very good friend of mine, and he's president of Pakistan Society of Metabolic and Bariatric Surgery. We together were with him in theater. So Mumtaz Saab started ahead of me, and I was a few months late. But once I started, I never looked back then.
Sir, excellent. And really, it's great honor to interview such a great personality. Definitely tonight, it will be a great session especially for youngsters. Sir, because our viewers also, we have youngsters from all over the world. Due to this, there are some question, a basic question. So first, my first question regarding a setup and minimum team for a Runway gastric bypass.
Imran, the minimum team, I mean, we are practicing in developing world. We are not ideal setup. But having said that, Shifa International, we maintain, we are JCI accredited hospital. And I personally started with dietitian on board, one, endocrinologist, second, obviously anesthetist is part and parcel of every procedure. That was, and the next challenge was the operation theater table. We didn't have a proper operation table in the beginning when I started bariatric surgery. And then friends like yourself and other people told me that you are going to become a center of excellence and you should start looking at things like the size of the washroom door, whether the patient can, obese patient can walk in there, or can be rolled with a wheelchair inside the washroom. Similarly, close appropriate size gears for the patient, X-ray table for the patient, and so many things we had to develop over a period of year or so. And still I'm learning. We keep on improving things. But I think the minimum was you need a good anesthetist, obviously. You need a good assistant, and you need a good cameraman. And you will be surprised to know that whenever I go for a workshop, I take my own team with me. If not an anesthetist, my assistant, technical expert, who is my right-hand person on assisting me, and the camera person is always my own. So obviously workshop is not ideal circumstances you're operating in, but if you got your own team, that makes life a lot easier for you. Pre-op, obviously you need support of good dietitian, you need support of a good endocrinologist, you need support of a psychiatrist. And I'm thankful to Allah that we got all those specialties under the same roof.
Sir, excellent. I remember. So you have highlighted. So these are the basic things and a great message, in my opinion, for our youngsters. I remember in 2018, when we apply here in Dubai, our hospital for Center of Excellence for Bariatric Surgery, Professor Neil Hutcher, he is president. He was president of SRC USA. He has visited our hospital, and I remember at that time, but he asked me, so because our hospital looking is okay, just beautiful, everything okay. He asked me, I want to see the wheelchair. So for your obese people, I want to see the washroom. So the seat, you can't believe. And yes, everything was okay. Thanks God. And also other things and many things, just like, so dress up, which dress so far that obese people have used specific dress, everything we had. And then our hospital was one of the first hospital in Dubai, take Center of Excellence. And thanks God also at that time, I also received as a Master of Surgeon. Sir, we will continue our discussion because we have divided these questions in 3 parts: pre-op, patient selection, some technical points, and post-op. One of the most important point is patient selection, and also in my opinion, the most important, which patient is not good candidate for this surgery. According to your opinion, what is the relative and absolute contraindication of Runway gastric bypass?
Imran, relative contraindications are many. I mean, relative contraindications, you might say somebody has had multiple laparotomies or they have had adhesions, and you feel that the operation is going to be a difficult one and you are going to, it's going to take a long time. I think those are sort of patients where you should go for a relatively simpler and quicker procedure, or you feel patient is otherwise, because of so many comorbidities, not fit enough to sustain the relatively lengthy procedure. I personally feel I have had done very difficult cases, and very occasionally I regretted that why did I put myself under so much stress? But by and large, you get away with it. Sometimes they are super obese patients, particularly when I started. Ironically, in the beginning, I put hands on super obese patients. And that took me a long time to accomplish the procedure, but lucky enough, I got away with it. I didn't have any complications or anything. But later on with experience, you become a little wise, and then you are careful in selecting your patients. For me, I personally would not operate, perform a Roux-en-Y gastric bypass if somebody is obese and there is, if the liver is looking cirrhotic. I wouldn't risk on that. The other thing is, I don't offer Roux-en-Y gastric bypass to patients who are in teenagers particularly. I mean, these are patients on the one extreme, and the other is patients who are above 60. These are the two extremes that I would prefer not to do them. But Imran, if you are yourself a bariatric surgeon, you come across a group of patients who have made up their minds, and they would say, look, you operated on my cousin, he has lost significant weight, we are the same age group, and I'm a bit diabetic, but it's all right, I want to sleep. So you have to educate them that what are the problems with sleep, what are the problems with bypass, what are the pros and cons, and then they have to come up or make up their mind, and you proceed accordingly. These are sort of 50-50 cases. I would never ever operate or do a sleeve on a patient who has significant reflux, or patients who have got large hiatus hernia. These are sort of patients I would prefer to convince them to come for Roux-en-Y gastric bypass. The rest is, I told you, the range is between 20 and 60, depending a lot in the BMI and the comorbids and all. My favorite procedure today is Roux-en-Y gastric bypass. And
sir,
you know.
Sir, excellent. Sir, what is your opinion about smokers? Are you also sensitive for such cases?
Good question. Smokers, I try to tell them, I try to convince them not to smoke, because smoking and Roux-en-Y gastric bypass, they don't go together. They have very high incidence of marginal ulcer. But interestingly, I tell you, I have experienced seeing people with marginal ulcer, in fact, one perforated ulcer as well. And these are the patients who were drinking alcohol at the same time they were smokers. 4 patients I have come across: one perforated ulcer, another one a bad ulcer which was about to perforate, and another bleeding ulcer, and another ulcer. So these are 4 cases, and 4 of them, they were having smoking with alcohol.
Sir, if we talk about patients who are using chronic NSAIDs due to arthritis or any issue. So how you deal in these cases? Because patient is taking this NSAID and now you are going to do Runway gastric bypass. So what's your protocol?
Imran, that's another good question. I personally think that these patients are prone to have duodenal ulcers anyway, or for that matter, gastric ulcers or duodenal ulcer. But with Runway, I would say they are higher risk group, no doubt. But normally, we keep these patients on PPIs anyway. And I haven't seen yet a single case. Maybe they haven't come to me yet that bad that they are taking multiple anti-inflammatory medications. But in theory, yes, that is a high-risk group, and they can have marginal ulcers. I personally would prefer sleeve rather than Runway gastric bypass if they are prone to that. I mean, people who are taking a lot of medications, not now and then anti-inflammatory for arthritis or backache and things like that. Occasional ones are okay, but people who are taking 2 or 3 medications on regular basis, I think one should be careful.
Sir, just your message. So if I conclude this one, if someone who has not GI reflux, this gastroesophageal reflux, and there is no contraindication of a sleeve gastrectomy, that is not, there is a not specific contraindication for a sleeve, but patient is using NSAID or smoker, so you prefer to go for a sleeve gastrectomy.
Yes.
Okay. Sir, regarding pre-op endoscopy, have you any protocol and H pylori eradication?
Imran, H pylori, if the patients are symptomatic, we do go for upper GI endoscopy. The problem is in our setup, our patients are extremely reluctant to go for upper GI endoscopy for some reason. They think they're going to die with this. They would rather prefer to have an upper GI series or a CT for that matter with the oral contrast, but not upper GI endoscopy. And it's extremely difficult task to convince them to go for upper GI endoscopy. So that is something I don't know, because I've been working in the West for nearly 11, 12 years. And over there, you recommend endoscopy and the patient would accept it straight away. But in our setup, it's an extremely uphill task to convince them to go for endoscopy. I don't know about your experience in Dubai, but here in Pakistan, Islamabad, they are relatively more educated class, come to us, they're rich people, but the upper GI endoscopy, no way, no.
Sir, what about H pylori? So you can also take H pylori test with the...
We do H pylori eradication pre-op. If diagnosed, if these patients are symptomatic with upper GI symptoms, I always do an upper abdominal ultrasound and at the same time, upper GI endoscopy. And if H pylori positive, then we eradicate them before surgery. But having said that, we routinely, in sleeve gastrectomy, we sent the resected stomach for histopathology and at the same time for H pylori. So if it turns out to be positive, obviously we treat them.
Treat them after surgery. Excellent, sir. Sir, now we will go some technical questions. So this is the one thing that I must highlight. Every surgeon, so this is the evolution of technique. If you're doing lab chole, definitely that lab chole that you were doing 10 years ago, no, little different. So now more than 1 decade, you are involving in bariatric surgery. So we are interested to hear from your side those technical points you have evaluate in your technique for Runway gastric bypass for better results?
Imran, before I started Runway gastric bypass, I visited a few centers and I watched the experts doing it. But honestly, I started doing things, every surgeon does the same, things which you feel you are comfortable with, you adopt that sort of strategy or way of doing it. I started it and till now, I started with a BP limb of 50 centimeters. And you will be surprised to know that now the BP limb, according to the BMI, can take it up to 100 centimeters. So that is the gradual change or shift. Looking at the, obviously, your patient's feedback and you follow up, see how much do they lose and their symptoms and all. Similarly, now pouch, I never compromised on the pouch. I always make a 4 centimeter pouch, not larger than that. And the diameter is 3 centimeters. Gastroject is 3 centimeters. That is my standard technique. Now the ruling, obviously it changes, but I personally prefer that shouldn't take cumulative to not more than 2 meters. Like if I take a BP limb of 100, my rule limb is 100 as well. If my BP limb is 80, my rule limb is 120 centimeters. Many malabsorptive procedures, people would measure the total bowel length, particularly redo procedures. I have the feeling sometimes that we should measure the total bowel length in case of Runway primary procedure as well. The reason I'm saying that, I did a laparotomy on a patient a few months ago whose total bowel length I measured was 4 meters. Now, you see, I mean, this is a wide range, but I said, in my opinion, I think people whose total bowel length is 7 meters, if you bypass 2 meters, that's not going to make much difference to him. So that's just my own feelings. I didn't study those patients, but what I'm saying is, are these the patients who come with failure in terms of weight loss? We see it in sleeve, we see that in single anastomosis, or you see that in Runway. There are failures. The percentage might be a bit higher or higher in sleeve or other procedures. But what I'm saying is, that's my own thinking. Maybe I'm wrong, but I feel that we should measure the total. I'm quite hopeful a day will come, then people would start thinking about these things.
Yeah, sure, sir. So Professor Laurent is also live with us, and also he accepts endoscopy in UAE is also very difficult, as same thing facing in Dubai. Thanks, Sir Laurent. Always you are sportive. Sir, regarding this BP limb, that is really, in my opinion, now a challenge, and we cannot standardize this BP limb in your practice. So have you any standard like the BMI of patient, age of patient, and any comorbidity? The dominant one is diabetes. Just imagine patient with 60 plus BMI, 45 years old, patient 60 plus BMI, 60 years old, or patient 60 plus BMI, 20 years old. So have you any criteria or no? Just you will go for 100 and 100 and so?
No. I think with the BMI, the higher the BMI, the longer should be the BP limb. The more the comorbids, particularly as you mentioned, diabetes, I would prefer to have longer BP limb. Younger patients, I would prefer to keep them within 60, 70 centimeters, not more than that. But the more obese they are, I think we need to have a longer BP limb. And BP limb is the one which would determine the outcome of your procedure.
Sir, why I'm asking? Because if you imagine just a patient is 20, 25 years old, and so age is in the, so normally if we standard, so 80. So he will be with this anatomical changes for 60 years. So he must go with this, and also he will eat after after 2-3 years. So there is some adaptation, and patient can eat, and we will also discuss in post-op about weight regain. And in a patient with 60 years old, again, it is in the hand of God, but overall life expectancy. So there is more chance of, because just imagine after menopause, already there is osteoporosis.
Yeah.
This female is suffering with this. And so what we do in this case, because these are very important, we cannot deal with a patient who is 45 years, healthy, and also he can eat everything. A patient who is menopause with symptomatic osteoporosis, how you deal with this patient, especially BP limb?
Imran, the thing is, nobody knows exactly why, like in the beginning, in the first 100 cases or so, my BP limb was about 60, 70 centimeters for every patient, irrespective of the age or comorbidities and BMI. Now, surprisingly, I've seen patients that is 5 years follow-up with iron deficiency anemia. You know, vitamin D, genetically we are deficient in vitamin D deficiency. Very occasionally B12 deficiency. Now, the thing is, if you are having deficiencies with that BP limb of 60 to 70 centimeters, now if you go on to 100 or 120 centimeters, you are going to have double the number of patients. Now, the other thing is, are we going to have maximum absorption of micronutrients in the first 50 centimeters, from the first 50 centimeters of the jejunum? If that is the case, it doesn't matter whether you increase it to 100 or 120. If somebody studies that how much portion of the jejunum is involved in iron absorption, how much portion lengthwise is involved in micronutrients absorption, I think there's still a lot to be done in bariatric surgery, and it's still evolving. We moved from band to sleeve, now from sleeve to bypass was already there, but it's becoming more common. Now people have started one anastomosis bypass, which is becoming very popular, going up. Now we need, who knows, 10 years down the line, maybe there would be other procedures coming up, and we would say what today we are doing, these are things of the past, and there'll be new procedures coming up.
Sir, absolutely agree. And really, you have highlighted excellent points. So if we see which part of jejunum is important for this micronutrients absorption, this is the base. So if we increase BP limb, yes, we achieve more weight loss, but also we will face this micronutrient deficiency. Maybe if this length is not much, and maybe we will not achieve that weight loss, but again, there is less malnutrition. These are very important, especially in our area. When a patient from a rural area and will back and there is no proper follow-up, absolutely agree, sir, with you. So regarding hiatal hernia in a patient with the large size hiatal hernia, what is your standard? Which size of hiatal hernia you prefer to repair?
Honestly, I don't believe in the size that much. I believe in the symptoms. How much problem is the patient having? Is the patient having GERD or not? Is the patient taking, somebody is on PPIs for more than 2 years or 3 years on regular basis, and the hernia size says it's 3 centimeters. On the standard teachings are that it should be more than or 4 centimeters or more than that. I wouldn't wait for the hernia to become 4 centimeters and then I will operate. If it's 3 centimeters, fair enough. My patient is symptomatic. I'm going to have a bypass and I will repair it.
Excellent, sir. Sir, regarding, we have two main concerns after Runway gastric bypass. One is marginal ulcer. Again, we will discuss. And other one is internal hernia. Again, we will discuss. So my question now, and technically, are you close defects that Peterson and JJ? Or if you're not close, have you faced any internal hernia?
Many people would not agree with me, but I have to be honest. I closed the pseudo-Peterson space or defect in my first 50 cases of Runway. And then I stopped doing it because many people thought that there is no point in closing it. Many senior colleagues, they were not in favor of closing the Peterson defect. We had a conference in Lahore, and a few of, when I was presenting my 150 cases, and one of our colleagues, he objected to that. And he said, this is a procedure which is going to be there lifelong. So you must close the defect. And then when I came back, there was discussion on that. And there were people in favor of and against the closure. But when I came back, I started closing it in every case, particularly the Peterson defect. Now, what happened was about 3 months ago, a patient of mine, he presented to ER with severe abdominal pain. I took him for diagnostic laparoscopy, and the lady had complete gangrene of the BP limb. And that actually herniated through the Peterson space. What happened was I was using Prolene routinely, a purse string suture, for closure of the defect. And that Prolene apparently had cut through. It's fat, mesentery is fat, it's something. And that caused total gangrene of that segment. I had to open it up, and luckily, the anastomosis was about 3 centimeters from the DJ with the limb, and the lady survived without any complications. She's all right now. Since that day, I stopped closing it. Somebody then told me that your technique is that you bring the whole loop first to the pouch, the gastric pouch. You make your anastomosis over there. Then you do your JJ and then divide the BP limb close to the stomach. So you got a long limb of a limb, where if there is a hernia in the first place, there won't be. If there is, the bowel can freely go to some people who have another technique, like one of our colleagues, he did it in Peshawar. You were in that workshop as well. That is a different technique. In that, I think you need to close these defects. Otherwise, they're going to give you trouble. But with our long limb, which is lying anticolic, very free, I don't think there is any danger of gangrenous bowel through that. I don't know. Maybe people who have done thousands, they might have come across cases where they would have seen strangulation of the bowel. But I am scared. I very selectively would close it, but not routinely. No.
Excellent, sir. Excellent. And routinely, so we see this internal hernia in JJ defect routinely because that is a smaller size. And in Peterson or pseudo Peterson, because just like MGB or OAGB, because we have a sufficient space, maybe there will be some telescopic movements, but less chance of gangrene. And as you have mentioned, if we will close, if we will not close properly, or if there will be, that will be smaller defect, and there is more chance of such a strangulation. So now we will go ahead for in post-op session. So we have completed pre-op, patient selection, excellent, and also technical points. Sir, have you any protocol of post-op endoscopy, this surveillance of endoscopy? Have you any protocol?
No protocol.
No.
Sorry,
Only in symptomatic patients.
Only symptomatic patients, only patients who have hematemesis or melena, where you are suspecting marginal ulcer. I have yet to come across stenosis of the JJ anastomosis. That is one thing. And odd dumping is all right, but I haven't come across a single case of stenosis.
Sir, which percentage of your patient after Runway gastric bypass were symptomatic? About
in terms of
overall symptomatic, they consult to you with this. You suspected maybe this is marginal ulcer. So because we are talking about endoscopy, and you did endoscopy.
Yeah, that is, I think people who experience vomiting or dysphagia, that is a common problem. Weakness, obviously, with every bariatric procedure, they can experience weakness. You have to give them supplements. But I think mainly that's not immediately post-op, but after 2 or 3 years, maybe follow-up, an odd one might come and they would say they find it difficult to swallow. Again, I would say I would love to send them for upper GI endoscopy, but they deny that. And then we have to do gastrographin or barium swallow. And if there is a problem, then obviously you have to correct it. But as I mentioned, I haven't seen a stenosis till date. And endoscopy only for marginal ulcers or if I'm suspecting it.
Sir, excellent. Sir, have you any protocol of PPI? So how long time you prefer to prescribe PPI and which dose for your patient after Runway gastric bypass?
Imran, initially I was not very enthusiastic about PPIs. I would use it for 2-3 weeks or maybe 4 weeks. But since I started seeing marginal ulcers, now my protocol is that we give, if I'm using omeprazole, I use 40 milligram twice daily for first 2 weeks, and then I use 40 milligram once daily for 3 months.
Excellent.
And obviously, accordingly, if the patients are symptomatic.
Have you any difference between the patient who was suffering with H pylori or previous GERD symptoms, and you did and also endoscopy? Yes, just there is esophagitis. Then your protocol will be different. Will be longer.
It would be. It would definitely be longer. And I might go up to 6 months even.
Till 6 months. And in a patient with H pylori positive, just you eradicate H pylori, and again, if patient will back with the symptoms, are you also prefer to rule out again H pylori? Maybe again this will be positive.
I would refer these patients to gastroenterologist.
Gastroenterologist, okay.
Yeah, because I can't do everything myself.
Yeah,
you know, it's
a team,
teamwork, and you need to get your colleagues engaged.
Definite, sir. Definite. And this is the most important message, in my opinion, for our youngsters. If you are going to start bariatric surgery or Runway gastric, need MDT. This bariatric surgery is not just like hernia or lap poly. This is lifelong follow-up. Sir, we will go ahead regarding, you have mentioned also you faced perforation of marginal ulcer. Have you faced any intractable marginal ulcer, not perforation? Intractable, no response to any PPI, anything. And then you revise this surgically, this procedure. Have you faced?
Yeah. As I said, one of my patient, I shouldn't say he or she, but one of my patient was smoker and also addict, alcohol addict. And what happened was the patient presented, rather was experiencing, and this was the patient which has had sleeve gastrectomy done about 10 years ago. And then the patient came for revision surgery. So we did a Runway gastric bypass because the patient was having reflux and small hiatus hernia as well, about 3-4 centimeters. So we did a Runway, and initially the patient did very well. No problems, no symptoms at all. Then after 1 year, patient started vomiting, can't swallow things properly, and there is pain in the epigastrium. And then we asked for upper GI endoscopy. And the upper GI endoscopy, she didn't go for upper GI, as I mentioned. So she went for a CT scan instead. The CT scan surprisingly mentioned that there is a 4 centimeter hernia. And I got so upset, and I said with Ruin, why should the patient have 4 centimeter hernia? But anyway, we decided to operate on the patient. I did a laparoscopy, and I came across a bad ulcer which was sitting on the gastric remnant and about to perforate into the gastric remnant. It was on the posterior wall. So I had to dismantle my anastomosis and redo it. But at the same time, I kept on chasing the pouch because the CT scan had shown that there was a hernia. There was no hernia. The CT scan described the pouch as a hernia.
Yes.
That was not
Yes.
a hernia.
Yes.
4 centimeter was the pouch, 4 centimeter was not a hernia. Anyway, so we did that. We gastrogage after resecting that area, and then kept her on PPIs. And she presented about 6 months 6 months later, again with epigastric pain. And so we did an upper GI endoscopy, and it was perfectly normal. So we gave her symptomatic treatment, and she's okay now. So these are sort of patients that could be challenging. I mean, I'm lucky that I'm working in a very good setup, but in developing countries, the supportive, the support facilities like your X-rays, your labs, the reporting might not be of standard. If you get a substandard report, and if you don't follow it, I mean, everything is clinically not clear. So you have to rely on them. And if you don't act, you are in trouble. If you do act, again, you are in trouble.
Definitely, sir. I have visited your setup. Excellent, amazing. And just my suggestion, maybe you will do in future, because I know our people, they don't like upper endoscopy. If you have this setup in your operation room, so during surgery, yes, you can see, because if we have this look before surgery, maybe it will be good enough. And now many bariatric surgeons, till I also have, personally, I have this setup in my OR. So endoscopy we will do within 5 minutes. Okay, there is then no issue, and we will go. And no charge, nothing charge, no charge for the patient, because we also have such issues here also. But we do this.
I think we should. We got an upper GI scope in our OR as well,
Yeah.
but it's not a video scope. And today, as we speak, I mean, without video endoscopy, you can't survive because you got so many trainees around you, medical students around you, and they would like to see what an ulcer would look like. Imran, when I was doing my training in the beginning, when I was in Ireland, we didn't have video scopes those days, and the consultant would tell us, come on, doc, have a look. This is the ulcer,
Yeah.
okay? And by the time he would show the scope to us, the ulcer would have disappeared, and we would say, "Oh, yeah." What? Yeah, we couldn't see anything.
Agree.
Yeah, so those were difficult days.
Sir, one of the issue after Runway gastric bypass and we are facing is weight regain, because now you have experienced more than 1 decade. Definitely, you are also facing. And in my opinion, every type of surgery, because till now you can't believe I am facing weight regain after OAGB. Till with that malabsorption after 6 years, 7 years. So now I did patient, I remember in 2013, and his weight was at that time 228. He lost weight till 100 and now again gained 34 kg after this period. So which percentage of your patients are suffering with weight regain after Runway gastric bypass?
I think, Imran, it is not immediate weight regain. I mean, if you look at them after 5 years, after 10 years, then you'd see that the number increases with time.
Yeah.
The good thing is, if I compare it with sleeve, the weight regain in sleeve is tremendous, phenomenal. The weight regain in Runway bypass is always there, but it stays between 10 kg, 15 kg, 5 kgs, like that. Very occasionally, I'm facing rather another problem, that failure to lose weight.
Yeah.
Some cases, they would say, like somebody's weight was 130 kg, and I see the patient after 8-9 months, how much did you lose? And the patient would say 20 kgs.
Yeah.
I said, the procedure we can do for 20 kgs.
Yeah.
What did I do? Did you do anything wrong? I did something wrong. And the answer is nobody did anything wrong. It's just the nature. So I think weight regain is a problem with every bariatric procedure, more so with sleeve, and then Runway, and now you are saying that you see them after more malabsorptive procedures as well. That is a fact. We can't deny that.
Yeah, sir, in such a case that you have mentioned, so in some cases, yes, definite. Also, I am facing in after OAGB, sometimes they stuck, weight stuck, okay, 30 kg, 40 kg lost, but the excess body weight was 60, 70. You prefer to use any GLP derivatives?
I think semaglutide is quite promising. And I heard the FDA has approved it as well for weight loss. I recommended it to a couple of my patients, and I have to see their results. They haven't come back to me, to be honest with you, and I'll see that. I think it's a good adjunct to the medical management of these patients, because revision surgery for those sort of patients whose weight regain is 15 kg or 10 kgs is asking for too much. And if you have non-surgical ways of dealing with it, it would be a good tool. Are you using it? I'm sorry, you are interviewing me, but I'm just for my own knowledge.
Yeah.
Did you use this? Huh?
Personally,
GLP?
I'm using, sir, I am using, and excellent results. Many times I use for my patients when they stuck, and just now also I have a patient, I did OAGB. She's from Canada. And then her weight, she lose weight and then stuck. And
Right.
wait, dietitian, something, oh no, nothing. And then I started the Truly City. That is also one of the derivatives, a weekly one injection, 1.5 milligram, and excellent results just after 4 injections, because
Mhm.
weekly one injection. And then she started to lose weight.
That's very good.
So yeah, it was amazing for me. And now, yes, she's happy and everything is okay. Yes, sir. I use, and also in weight regain, also I prefer. I use.
Great. Great. Now, on the other side, I see patients who would call me 6 weeks or maybe 8 weeks or 3 months after surgery, and they would say, "Doctor, for the last 2 weeks, I haven't lost a single kilogram of weight.
Yeah.
Why is this?" And I said, "Just relax. There is usually a pause for a week or two, then you will start losing it again." And then I don't hear from them. So apparently they are losing weight then. That's one thing which I have observed during this course of period of weight loss in the first year or so. Other than that, as an adjunct, I don't use it routinely. The couple of patients I have tried this were those who were 3 years post-Runway gastric bypass, and they had gained about 10 or 12 kgs in weight.
Sir, excellent. Sir, we are also surgeon and we are also scientist. We love our patient. We love our practice. What is your main concern after Runway gastric bypass? And which complication always you think, when I will do this surgery for this patient, maybe this will happen, this will happen.
I think since I saw this gangrenous bowel, I don't close the Peterson space, and I'm not worried about now. I'm relaxed. I'm not worried about the bowel strangulation. Now, as long as the weight regain is concerned, we discussed it. This can happen in any procedure. I think deficiencies, micronutrient deficiencies are there, and we always replace them. Other than that, I personally found Roux-en-Y gastric bypass a very relatively innocent procedure. That if you look at it at more malabsorptive procedures, where you have to treat your patient with supplements very aggressively or regular follow-up they need, our patients disappear. Would you believe it? They just appear 4 years following Roux-en-Y gastric bypass. And I said, "Did you have any blood tests done?" "No, nothing." "Are you having any problems?" "No, just sometimes some weakness." And you'll be surprised to know that these patients, if I do start doing more malabsorptive procedures, what will they do? I mean, I probably will ruin their quality of life. No, you are an expert on single anastomosis. I don't want to discuss that. But I'm talking about more malabsorptive procedure like SADI. I was very much interested and keen to start SADI procedure. But I attended a few courses online, and I asked the guys, and I said, "How is the quality of life?" "Well, the quality of life is good, but if the patient goes to the toilet, then for half an hour, there is foul smell in that area and nobody can attend that washroom." I said, "No, not in our setup. It's not acceptable here. I'm not going to do it." So far, I have refrained from it. But I think more malabsorptive procedure needs a really close follow-up.
Sir, absolutely agree. And really, this is the great message again for our youngsters. If you're going to start, so please, when MDT and also this malabsorptive or hypoabsorptive procedure, yes, apparently, yes, patient will lose weight, everything okay, but everything is not okay. And these things are very important. Sorry, we will go ahead. So I remember, so when we start, I was just, so see this bariatric surgery. So they start bariatric surgery with gastric bending, sleeve, Runway, and go ahead. And then in this OAGB, and also we have no idea in future what will happen. So how you predict the future of Runway gastric bypass?
Runway gastric bypass is time-tested procedure. It is not going to lose its ground. I think there are definite indications for this procedure. Even if another procedure, which may be less malabsorptive, will give you similar results, but Runway has, like somebody who's got a hiatus hernia with a reflux, or somebody has had a sleeve and there is a stricture at the incisura, or for that matter, patients with a single anastomosis gastric bypass, where somebody who is not properly trained and they left a pouch which is relatively short, and your patient comes up with severe reflux. And these are sort of definite indications that whether you like it or not, you should do Runway gastric bypass, because it will solve the problem. Other than that, I personally, so far, I am very selective in doing single anastomosis. I would prefer single anastomosis to be, at the moment, I can't say anything in the next year or so. People who are super obese, they are good candidates for malabsorptive procedures. And also people who are wheelchair bound or bedridden, and they need to, with a lot of comorbids, particularly uncontrolled diabetes. I have done a limited number of cases with excellent results in those patients.
Sir, excellent. So, sir, I am also follower of Runway, and just with all respects, you think in future this will be only a rescue operation?
No.
Not initial surgery. So for complication of
What I'm saying is, if everything in future, if even it becomes unpopular in a sense, this has been time-tested procedure. It's a long history. It's not a new procedure. People, even when there was no laparoscope with open surgery, people were doing Runway gastric bypasses. But what I'm saying is, if something new comes up, which replaces Runway gastric bypass, again, its value as a rescue operation still persists.
Sir, thank you. Sir, now I think this is going to finish 1 hour. And as you have mentioned earlier, so really so much thanks. You were tired. You had a lot of cases today, and a difficult one. That was a hiatal hernia and your last surgery. And really appreciable. Sir, your message for our youngsters who are just now going to start Runway gastric bypass or any type of bariatric.
I would request the youngsters not to start with complicated cases or with patients whose BMI is more than 50. For the beginners, you choose your cases very carefully, and you guys are lucky. There are so many bariatric surgeons around. They can help you, they can teach you. Difficult time was ours when we started. The bariatric surgery was going through a phase of evolution, and that was a tough time for us. For you guys, you make proper selection of cases. I would say, start with sleeve gastrectomy, which is technically relatively easy procedure, but you must have attended workshops, courses, and you should know about the outcome or the prospects of that procedure. That is one thing. The other is, if you want to start bariatric surgery, you start it as a bariatric surgeon. We ourselves, we went through, as I mentioned earlier, starting with the gallbladder and then went up to hernias and splenectomies and so many things. For you, basic laparoscopic skills are very important. You must know that. The second thing is suturing, intracorporeal suturing. Whenever you get a chance, whether on endo trainer or in the operating room live, you must know how to stitch. If there is a small defect in the bowel or in the stomach somewhere, I wouldn't like you to be opening up the abdomen for that. You, as a bariatric surgeon, must have the competence to close that defect with suturing. And then obviously when you are going from sleeve to bypasses, then you would have enough skills to accomplish the procedure.
Sir, so much thanks. And really, today was one of the best session, very friendly, and you have shared your experience. And so much thanks on my viewers that they follow from, now I can see from Yemen, from different countries, Arabic countries, Middle East, they are live with us. And so much thanks, sir. This was a great session. And also my viewers, so much thanks. And we will continue this series of Runway gastric bypass. And next week, Tuesday, 10 p.m., we will be with another legendary bariatric surgeon. I need your support and guidance. If you have any question, you can ask in comments. Professor will respond. If you have any question regarding Runway gastric bypass, you can send me personally message and also in comments. Sir, again, so much thanks for your time. And I need your support, sir.
Thank you very much for having me. Thank you.
Thank you, sir. Have a nice time, sir.
You too. Thank you.
Thank you, sir.